Hello and welcome. My name is Elizabeth Wade, and I have shared a short summary of my professional background at the end of these slides. The title of this presentation is Risk Reduction Tools. This is the relevant financial relationship disclosure for this presentation. These are the learning objectives that will be addressed during this presentation. These are the key abbreviations that will be used in this presentation. These are the key definitions that will be used in this presentation. By the end of the presentation, you should be able to answer two self-assessment questions. The first one is, which one of the following is an example of a forcing function? Is it A, free flow prevention mechanism on large volume infusion pumps? B, drug-drug interaction alerts to prescribers upon medication order entry? C, restricting the ordering of a medication to a specific provider group? Or D, separate locations of two similar patch strengths in storage locations? The second question you should be able to answer is when developing a medication safety improvement plan, select one risk reduction strategy for implementation so as not to confuse the staff, preferably one that is the easiest to accomplish. Is that true, A, or B, false? When we return to the assessment questions at the end of the presentation, I'll provide the answer and discuss the rationale for both of these questions. This diagram that you see here is the meat of the risk reduction module. This is the rank order of risk reduction strategies from highest to lowest effectiveness. This was adapted from the Institute for Safe Medication Practices hierarchy of effectiveness. From the top, you have the highest leverage risk reduction strategies going down to medium, moving down to your lowest risk reduction strategies. The higher leverage risk reduction strategies tend to lean more heavily on system reliability, whereas the low leverage risk reduction strategies tend to lean more on human reliability. The system reliability risk reduction strategies have long-lasting effectiveness on a medication use process, whereas the ones that rely on humans in order to be effective tend to be not as long-lasting and can certainly have an impact if there's staff turnover and be less effective. You'll see that in the high leverage, we have forcing functions, barriers and fail-safes, automation and computeration. Within the medium leverage group, there's standardization and protocols, redundancies, and warnings, alerts, reminders, and checklists. And finally, within our low leverage group, not to say that these are not important to do, they're just not as effective in the long run, you have rules and policies, educational programs, information, and suggestions to be more careful, which I guess that last one probably wouldn't count as a risk reduction strategy at all. We'll be talking about each one of these risk reduction tools in more detail. Remember that when we think about the risk reduction strategies on the prior slide, we want to select the highest leverage risk reduction tools possible. However, a lot of the times, those highest leverage tools like forcing functions and automation might not be feasible or fiscally feasible in the current process and systems that you have. Furthermore, there's often unintended consequences that may outweigh the benefit. So the higher leverage the strategy, oftentimes the more severe the unintended consequences. The lower leverage strategies are not going to be effective for long-lasting error prevention when used alone. They're often able to be used in support of higher leverage risk reduction strategies. One can argue that education is really important along with any risk reduction strategy and shouldn't be excluded. However, education alone is not going to be effective. We know that a combination of risk reduction tools may and should be used. We should use as many as possible to address the contributing factors that we identified. A fail-safe is one of the highest leverage risk reduction strategies one can implement in a system. Fail-safes anticipate that humans will err or drift, but no matter the change in product design or how individuals interact with the system, a fail-safe will prevent harm no matter what human error occurs. One example from the automobile industry is that someone might forget to put a car in park before turning off the car. And if you do this and you get out of the car, this car could roll off. The fail-safe in a car will not allow you to turn off the car if it's not in park, and this completely prevents any human error from resulting in a catastrophic outcome. An example from the medication use process is that a contributing factor could be a nurse may forget to clamp tubing prior to removing an IV administration set from an infusion pump. This could result in free flow of an IV medication into the patient. A failsafe in the infusion pump is that it automatically clamps upon removal of the IV set to prevent free flow of the medication. For another example of a fail-safe, here is another case where a provider ordered a fluid that contained half normal saline, 20 milliequivalents of potassium going at 100 mLs per hour. In this example, when the pharmacist received the order, the pharmacist needed to build the fluid manually. An error occurred when the pharmacist added the potassium chloride fluid additive, but the pharmacy system defaulted the dose of the injectable additive to the vial size. Therefore, the patient received 40 milliequivalents of potassium chloride in their fluid rather than 20 milliequivalents. A fail-safe in this case could be that the system would allow the pharmacist to add an additive for the injectable, but would not allow the pharmacist to proceed without adding a dose. So to clarify the error, the contributing factor was that the pharmacist could enter an order and forget to enter the dose of an IV additive medication. Since the system defaults the dose to the product size, there's nothing to remind the pharmacist that a dose needs to be entered. A fail-safe would be to default the dose to 0 during manual order entry of medications. This is not only a fail-safe, but a 0 dose doesn't really make sense, and it will make the error more visible if it were to go through to the technician for preparation. A potential unintended consequence is that this could get missed and the patient could not receive potassium. The second type of high leverage risk reduction strategy is a constraint. Constraints are when we limit access or limit the use of a medication or device to make it more difficult for an error to occur. Let's take another error case example to illustrate a constraint. In this new error, a patient received an injection of a neuromuscular blocking agent rather than a beta blocker on a critical care unit. Thankfully, the patient was already intubated. The contributing factor in this case was how the medications were stored. The practitioner inadvertently selected the neuromuscular blocking agent when pulling the medication out of the refrigerator. The refrigerator had open bins, and the neuromuscular blocking agents and beta blockers were in close proximity to one another. We can apply constraints to this particular error situation by removing neuromuscular blocking agents from the patient care areas to reduce the likelihood that someone would select the product in error. However, there are some areas that do need to stock these agents, so we can still sequester supply and somewhat restrict access to neuromuscular blocking agents by keeping them in locked intubation kits in a separate location. A potential unintended consequence of this might be a delay in care, and that's important to consider. However, in this case, we might argue that the benefit of a patient not being able to get a neuromuscular blocking agent inadvertently outweighs the risk of a very slight delay in care by having to access the neuromuscular blocking agents through a kit. In this image, you can see an example of an intubation kit kept in a critical care area. The neuromuscular blocking agents with the red caps are highlighted in the red box. Let's look at another error example. In this case, a provider discontinued argatroban before starting a patient on warfarin. The provider consulted with a specialty provider and misinterpreted the specialist's recommendation. The provider was unaware that the organization already had a policy for bridging to warfarin. The patient unfortunately became subtherapeutic for 24 hours prior to intervention. In this example, a constraint can be applied to restrict access to being able to order the medication. The contributing factor to this case was a knowledge deficit and miscommunication during provider handoff regarding bridging argatroban to warfarin. In this case, the organization chose to restrict ordering and discontinuation of argatroban to specialty provider groups only that had knowledge of its use. A potential unintended consequence of this is that we could delay the ordering of argatroban while contacting a specialty provider, or if a specialty provider is not readily available. When we discuss high leverage risk reduction strategies, you'll commonly hear the term forcing functions. Forcing functions are hard stops during a process. These hard stops can prevent human error or ensure important information is provided before proceeding. Let's take a look at another example. In this case, a patient was supposed to receive levetiracetam enteral liquid. A nurse obtained the medication unit dose from an automated dispensing cabinet and drew up the enteral liquid in an enteral syringe for nasogastric tube administration. Unfortunately, the nurse connected the syringe to the incorrect tube and administered the levetiracetam enteral liquid intravenously. A contributing factor in this case was that the enteral medication in an enteral syringe could be connected to IV tubing. A great forcing function here would be to implement ENFit syringes that are physically incompatible for connection with IV lines. Another way to implement a forcing function is through our computerization and automation. So this is a combined example of forcing function and automation. In this case, a patient with psoriatic arthritis was stable on methotrexate 15 milligrams orally weekly. In this error, the provider selected the incorrect frequency for methotrexate. Unfortunately, the provider selected daily during re-entry of the prescription. A forcing function that could be implemented using our automation and computerized provider order entry processes is to require a provider to select an oncologic indication in order to proceed with a daily methotrexate order. So far, we've talked about an example of a physical forcing function with enteral syringes and IV lines, a virtual forcing function through the provider order entry system with the limitation of ordering of daily methotrexate. And here's another example of a forcing function that's physical. In this case, we call it a soft forcing function because it makes someone stop before they grab a medication. And this is commonly used when storing medications. In this case, a pharmacy technician selected a fentanyl 50 microgram per hour transdermal patch instead of a 100 microgram per hour patch. Both patches are next to each other on the shelf, which is pretty common, and they both happen to have the same count in the automated dispensing cabinet. A soft forcing function would be to separate the locations of two similar patch strengths in storage locations. We can really do this with any look-alike, sound-alike medication or medication of the same generic product and ingredient but different strength. This forces the technician to move to a separate location to obtain a medication and reduces the likelihood of a mix-up. The last type of high leverage risk reduction strategy is automation and computerization. Also, in a world where we have electronic health records, this is often the most frequently sought after high leverage risk reduction strategy because it has such a high impact on our medication use processes. Automation and computerization limit reliance on human memory or capability with the use of technology. So this includes the use of alerts, rules, dosing calculator. A limitation of this is that alerts are easily overused, causing alert fatigue. We can have over-reliance on technology and a false sense of security. And automation and computerization is very challenging to maintain and utilizes a high number of informatics resources. We can typically see this especially when there's drug shortages and we need to pivot very quickly to update our automation. Let's discuss automation in the setting of another actual patient case that happened in a prior organization. In this case, a patient had abdominal hematoma after a splenectomy and was started on an epidural by anesthesia. The patient had a consult to another provider group for new onset atrial fibrillation. The consulting provider started the patient on aspirin and clopidogrel, and the anesthesiologist was unaware of the aspirin and clopidogrel being started in the setting of the epidural. The pharmacist discovered the concern and notified anesthesiology. In this case, miscommunication between provider groups was a major contributing factor to the error. The provider that was consulted and started the patient on aspirin and clopidogrel was not aware that the patient was on an epidural. The provider also might not have been aware that anesthesia needed to be consulted before starting antiplatelet or anticoagulant agents on the patient. We can apply automation and computerization in this case, so that if a provider attempts to order an antiplatelet or anticoagulant agent for a patient while an epidural is active on the patient's profile, that provider would receive an alert. Let's take a look at another case. In this case, a provider attempted to order cefotaxime for spontaneous bacterial peritonitis. Cefotaxime, unfortunately, is non-formulary in this organization. Upon searching for the medication, the provider could not find the non-formulary option for cefotaxime. The provider instead selected a look-alike, sound-alike medication option that was on formulary, cefoxitin instead. A pharmacist intervened upon patient review. The contributing factor to this error was that providers may search for non-formulary medications and inadvertently select a formulary medication with a similar look-alike, sound-alike name. We can leverage automation and computerization in this case by incorporating non-formulary options in the order entry system that still notify providers that the option is non-formulary and redirects them to a formulary alternative. In this case, if a provider selects cefotaxime, we could redirect that provider to order ceftriaxone instead. A potential unintended consequence of this is that providers might not be aware that they're being redirected to order an alternative. So we have to make sure that the provider interface and any interface is very clear as to what the computer system is doing. Informatics workload to build all of these non-formulary items also needs to be considered. A last great example of automation and computerization can be during the medication administration process. Let's take a look at an error where a patient may receive greater than the maximum recommended daily dose of acetaminophen. The contributing factor here is that the nurses may not be able to gather all of the acetaminophen doses administered in a 24-hour period and do the mental math that's required to figure out whether or not the patient's exceeded the recommended maximum daily dose. This is a great way to leverage automation, where the medication administration record can calculate that daily cumulative dose of acetaminophen. However, one unintended consequence is that the calculator may not be 100% reliable. One example could be that the calculator could take into account acetaminophen, but not all combination acetaminophen products. This could create a false potential sense of security for the nursing staff. Now we're going to move on to medium leverage strategies. Standardization is an example of a medium leverage strategy that is commonly used in combination with other higher leverage or similar leverage risk reduction strategies. Standardization is when we reduce complexity and variation in a process by creating a uniform model. Great examples of this include order sets and predefined orders, standard processes, and standard definitions. You'll likely see that we can't really implement standard order sets without also implementing automation and computerization of those order sets. Similarly, we'll be later talking about policies. It's difficult to implement standardization of standard definitions and processes without policies in place. Let's take a look at a patient case that illustrates standardization. In this case that was published by ISMP, a nurse placed a yellow wristband on the patient, which in this hospital was used to designate do not resuscitate or DNR status. The nurse happened to work at another hospital in which yellow wristbands meant something different. In that other hospital, the nurse was used to this wristband meaning to identify a restricted extremity, one that should not be used for drawing lab studies or IV access. Fortunately, the mistake was realized and the patient was resuscitated during a code situation. A contributing factor to this is that someone may interpret patient wristband colors differently due to meanings in different organizations. Standardization clearly has an opportunity to help improve this situation, so we can standardize wristband colors so that any healthcare institution you go to, the colors mean the same thing. A redundancy is a medium leverage strategy that is used to force additional checks in the process by incorporating duplicate steps or another individual in the process. The limitations are that this can be decreased in efficacy if it's not done independently. An example is that independent double checks for chemotherapy order verification and administration can be effective at helping to reduce the likelihood of an error from passing through the process. An example for redundancy is that we had a case in which a patient was scheduled to go to the OR for a tracheostomy. The patient was receiving heparin 5,000 units subcutaneously every 8 hours for DVT prophylaxis. The surgical provider entered preoperative orders, but did not place the heparin sub-Q on hold. Because of this, the surgery had to be delayed. A contributing factor here is that the surgical team may forget to address the patient's anticoagulation status prior to the patient going to surgery. In light of the absence of maybe some higher leverage strategies that could be put in place, in this example, we had a pharmacist process to review patients' medications prior to going to surgery for anticoagulant or antiplatelet agents. The last kind of medium leverage strategy that we're going to talk about are reminders and checklists and passive alerts. This is when we make information readily available or more visible. These can include operational methods sheets, which we'll talk about an example in a little bit, checklists, which are commonly applied to processes that are more complex, such as chemotherapy, pre-op, and finally, passive reminder alerts. This is going to be different than the active and more specific alerts to clinical scenarios that we find in automation and computerization. Think of these alerts as less smart, not really specific to a patient-specific situation, but they're simply there as reminders with information. In this error example, a nurse attempted to administer insulin to a patient but was unable to scan the medication because the barcode had been covered up by the pharmacy's patient-specific label. In this case, technicians forgot how to label insulin pens and vials in a way that didn't cover important information that was needed for administration. An operational methods sheet was developed to help remind technicians of the proper way to label insulin pens and vials. Here is an example of an operational methods sheet. This is where we provide a visual cue that's quickly and easily able to be understood and how to complete a process correctly. This is also a great way to provide standardization to how we label insulin pens. In another example, we had a patient arrive in the pre-surgical area without their appropriate medications on hold. This was an inpatient who was transferred and ready to go to the OR, except all of their inpatient orders were still active on their profile. Inpatient nurses have a variety of items to have to remember to do prior to sending a patient to surgery, and in this case, the nurse simply forgot one of those tasks. This is a great way to implement a reminder or checklist. A pre-op preparation checklist can be completed by the inpatient nurse prior to sending patients to surgery. Contacting the pharmacist to place a medication on hold was added to this checklist. We're now going to talk about low leverage risk reduction strategies. While the name suggests that low leverage means they're not going to be as effective, this simply means they're not going to be effective as in the long run to provide long-lasting change or process improvement. That doesn't mean, however, that we don't want to do them. Rules and policies, education and information, these are all foundational to important safety improvements, but they have to be used in concert with other higher leverage strategies. It's often important to have education. We can't argue with that. And it's often difficult to enforce or make a change without a policy as a foundation in place. Rules and policies help ensure that we communicate our best practices and processes. An example of this case would be that during administration of an albuterol inhaler, a nurse noticed that the inhaler actually belonged to another patient who was previously in that patient's room. In this organization, albuterol inhalers were kept at the bedside, and upon discharge, the nurses are supposed to clear out and clean out any patient-specific medication storage areas. But there was no policy in place to do so. A policy was developed for nurses or their designees to clear out patient-specific medication storage areas upon patient transfer or discharge. Last but not least, our lower leverage risk reduction strategy is education and information. This usually must always be combined with other risk reduction tools in order to be effective. This relies on human memory to remember information at a future point in time. And this includes newsletters, meeting discussions, posters, all great things to do for a medication safety program, but definitely don't want to do those alone. This is a great example of an educational campaign to help you remember the difference in dosing between hydromorphone and morphine. Hydromorphone would be equivalent of a home run, whereas morphine could be a touchdown. It's a great example and it helps stick and remember the difference in doses. However, someone has to remember and apply this specific piece of information at the point in time when they happen to be ordering, verifying, or administering a dose of these medications. Sometimes anecdotes are the most powerful, and this is where education and information with a good story via a newsletter can be really useful. Here's a great example of an article snippet from a newsletter that we published in a medication safety newsletter for the organization. This was a good catch by a nurse reviewing medications during morning med pass. The spouse had brought patients' medications from home. However, the medications that were brought in actually did not belong to that particular family member. The nurse made a good catch by identifying using 2 patient identifiers that those medications were not belonging to the patient. Now that we've reviewed all of the risk reduction tools in the rank order of risk reduction strategies, let's take a look at our self-assessment questions that we talked about at the beginning of the presentation. You should be able to answer them now. Which one of the following is an example of a forcing function? Is it A, a free flow prevention mechanism on a large volume infusion pump? B, a drug-drug interaction alert to prescribers upon medication order entry? C, restricting the ordering of a medication to a particular provider group? Or D, separating locations of two similar medication strengths in storage locations? If you answered D, you would be correct. In A, a free flow prevention mechanism on a large volume infusion pump would be a great example of a fail-safe. Drug-drug interaction alerts to prescribers upon medication order entry is a great example of automation and computerization. And C, by restricting ordering of a medication to a specific provider group, that would be considered a constraint. So in this case, separating locations of two similar patch strengths is a forcing function. The second question was true or false. When developing a medication safety improvement plan, select one risk reduction strategy for implementation so as not to confuse staff, preferably one that is the easiest to accomplish. The correct answer is B, false. When developing an improvement plan, we want to select a variety of risk reduction strategies that make sense for the contributing factor at hand. This is not to confuse staff, but to help protect staff by plugging in as many Swiss cheese holes as possible. And preferably, the higher leverage the risk reduction strategies, the better. Those are typically the most difficult ones to accomplish. In conclusion, when we're developing a medication safety improvement plan to address a contributing factor to an error, we want to select the highest leverage risk reduction tool that's possible while minimizing the unintended negative consequences on other processes or other possible errors. We should consider a combination of risk reduction tools to best protect the patient. When we're planning for the implementation, the feasibility of applying tools in the current medication use process has to be considered. These are the references used to develop this presentation. Thank you very much for your time and participation.